Okay, hello again. Today we will talk about an important subject known as irrigation and endodontics. Achieving a good and successful irrigation procedure is very important during root canal therapy as it may determine the long-term success of the treatment. Irrigation procedure is considered as the cornerstone of root canal therapy. First of all, we need to know what challenges are there that may prevent successful irrigation procedure. The first challenge is root canal system anatomy. The root canal system is not just a funnel, but rather it is composed of central area and lateral parts such as fins, anastomosis, and accessory canal. So our irrigation procedure must address this anatomical configuration and ensure their adequate cleaning to promote the success rate. Another factor we should consider is a smear layer. Smear layer is a surface film of debris retained on dentin surface after instrumentation with endodontic files. As we see in this image was taken with scanning electron microscope. The dentinal tubules are not opened sufficiently due to the accumulation of debris and smear layer. Any cutting instrument introduced within the root canal will cause smear layer and debris generation. The influence of this layer is that it contains bacteria and their byproducts. Also, it can prevent the penetration of intracanal medicaments into the dentinal tubule. Besides that, it will also influence the adaptation of filling material to the canal walls. This layer is composed mainly of two layers, which are the superficial and the deep layer. Another challenge that need to be considered is bacteria and microorganisms. The microorganisms in root canal system is so various, and it may contain gram-positive, gram-negative bacteria, fungi, and other microorganisms. All these microorganisms should be dealt with properly during root canal therapy, as they might reduce the success rate of the treatment. The bacteria in root canal system can occur either as planktonic bacteria or as bacterial biofilm. What do we mean by planktonic bacteria? Planktonic bacteria is a freely floating, non-adhering bacteria, while biofilm is a community of microorganisms that coexisting together and self-produce extracellular matrix. The biofilm are recognized as the dominant form of endodontic infection rather than the planktonic bacteria, and the bacteria in the biofilm are 100 to 1,000-fold more resistant to the antimicrobial agent than their free swimming correspondents. This will highlight the need for efficient disinfection procedure to reduce their detrimental effect on the outcome of the therapy. The most dangerous bacteria we can face in root canal therapy is Enterococcus faecalis, as it repeatedly isolated in cases of apical periodontitis, cases with failed root canal therapy, and this bacteria is highly resistant to irrigation solutions. Now, let's discuss the required properties of ideal irrigation agent that can get over the aforementioned challenges. The ideal irrigation agent should provide chemical, mechanical, and biological effects in order to be effective. What are the properties of ideal irrigation solution? The ideal irrigation solution should have antimicrobial properties in order to reduce the number and the virulence of microorganisms in root canal system. Another requirement, tissue solvent. What do we mean by that? The irrigation solution must dissolve pulpal tissue and organic debris within root canal system. The third requirement, flushing debris. The irrigation solution should be able to remove the debris and particles from the root canal system. Another requirement is lubricant in order to reduce the frictional forces that is generated during instrumentation procedure. In addition to that, the irrigation solution should possess the ability to eliminate or remove the smear layer generated during instrumentation procedure. The final requirement of the ideal irrigation solution is that it should be possess a low antigenic level and be little toxic to the periradicular tissue. Now, according to their chemical activity, irrigation solution could be divided into active or inactive irrigation solutions. The chemically inactive solutions, we are familiar with some of these types, such as normal saline and local anesthetic solutions. Now, let's compare the properties of these agents with the ideal requirements of irrigation solution. Flushing debris is good, lubrication action is good, they have low toxicity level, and they don't possess antimicrobial properties, neither tissue solving ability, and they fail to eliminate smear layer. Now, let's talk about the most common active irrigation solution. These are sodium hypochlorite, fluorexidine, and EDTA. We will start with sodium hypochlorite. Sodium hypochlorite is the gold standard, most widely used endodontic irrigation solution nowadays. This irrigating agent is used in wide range of concentration that lies between 0.5 up to 6%. Some authors suggest that higher concentration can be used, such as 7, 8, or up to 11% can be used in clinical application. However, 5.25% is the optimum concentration, and it has been widely investigated in the literature. The sodium hypochlorite used in root canal therapy is composed of sodium hypochlorite, sodium chloride, which make the solution isotonic, sodium hydroxide, which work as a pH modifier and a surfactant. Something we must consider is the difference between domestic preparation of sodium hypochlorite, which are intended to be used in daily work, such as house cleaning or any other purposes, and the dental preparation that are specially fabricated for dental uses. These dental preparations possess more alkalinity, as their pH range between 10 to 12. Besides that, their ability to dissolve vital and non-vital soft tissue is higher than domestic preparations. So, in our practice, we should use specially prepared dental preparation to achieve more effect. Now, how does sodium hypochlorite perform its job? When sodium hypochlorite contact water, it breaks into sodium hydroxide and hypochlorous acid in a dynamic reaction. The first sodium hypochlorite organic tissue dissolution mechanism is known as a saponification reaction. In this reaction, the hydroxyl ions are produced, which can damage bacteria and attack their phospholipids, while the second agent, which is hypochlorous acid, involved in a second reaction known as the chloramination reaction. In this reaction, the chloramine is produced, which irreversibly oxidize the bacterial enzymes and inhibit bacterial cell metabolism. An important thing we should mention here that the ability of sodium hypochlorite to dissolve tissues depends on many factors, such as sodium hypochlorite concentration. By increasing sodium hypochlorite concentration, this means we are increasing the available chlorine ions and increasing the dissolving ability of sodium hypochlorite. Other factor is temperature. Increasing temperature means we are increasing the activity of sodium hypochlorite particles, and this promote or boost the action of these particles. Agitation or activation of sodium hypochlorite increases its activity and penetration within the dentinal tubules, but it increased the dissolution rate of the sodium hypochlorite particles. Another factor that affects sodium hypochlorite dissolution activity is contact time. By increasing contact time, we are increasing the dissolving and the antibacterial ability of the sodium hypochlorite. But literature reported that prolonged contact time between the sodium hypochlorite particles and the dentine in the root canal walls might affect the bonding of resin-based cement and sealer to the dentine. So we shouldn't exceed 30 to 40 minutes time of contact between sodium hypochlorite to overcome this drawback. Another factor is solution refreshment. By refreshing periodically the solution of sodium hypochlorite inside the root canal, we are increasing the available chlorine ions that are active within the root canal walls. And the last factor is surfactant. These surfactant, or they are agents intended to increase the tissue penetration ability of the sodium hypochlorite inside the root canal wall and increase its penetration rate. But some studies have reported that these surfactants may reduce the available chlorine ions of sodium hypochlorite. Now, what are the limitations of sodium hypochlorite? The first limitation, sodium hypochlorite needs to be activated or agitated to increase its tissue penetration. If we don't use agitation method that is sufficient to increase the penetration of sodium hypochlorite, we're just soaking or rinsing the canal, and we will have a poor penetration ability of sodium hypochlorite. Another limitation is, as we said before, potency of sodium hypochlorite degrade over time as the particles start to degrade and interact with the dentine, so that we should repeatedly and routinely refresh the sodium hypochlorite solution inside the root canal. Degradation is also increased when sodium hypochlorite solution is exposed to heat and light. So when we store sodium hypochlorite preparation, we should ensure that the sodium hypochlorite is stored in dark containers away from high temperature in order to preserve its activity. Extrusion of small volumes of sodium hypochlorite into soft tissues or periradicular tissue can cause what is known sodium hypochlorite accident due to the high proteolytic or tissue dissolving ability of sodium hypochlorite. What do we do if patient exposed to such an incident? If sodium hypochlorite accident occurs, we need to manage it following this protocol. The first and most important step, the dentist shouldn't panic and explain to the patient what happened and what possible scenario the patient might experience, such as swelling, edema, ecchymosis, etc. Secondly, we should irrigate the root canal repeatedly with normal saline or distilled water to dilute the harmful effect of sodium hypochlorite particles. For pain control, we might prescribe acetaminophen, and put in mind, we should never ever prescribe non-steroidal anti-inflammatory drugs, as these drugs showed increased proteolytic activity and hemolysis. Some authors also recommend using of antibiotic for prevention of secondary infection, or maybe we also can use steroids to decrease the inflammatory procedure. An important thing we should do also to advise the patient to put cold packs to reduce the swelling at the first day and hot packs at the following 2 days to increase circulation and promote the healing. The major shortcoming of sodium hypochlorite is its inability to remove smear layer, so that we need another irrigation solution to do this job. Other limitation of sodium hypochlorite the patient commonly complain of is the unpleasant taste and odor of this agent. By using rubber dam isolation, we can overcome such an instance. Another important subject we should mention here is sodium hypochlorite heating. As we said before, increasing temperature of sodium hypochlorite will increase its proteolytic activity, increase its antimicrobial activity. So some studies reported that when the sodium hypochlorite is elevated to 60 degrees centigrade, it will possess higher and more beneficial activity. So some studies or authors reported that preheating of sodium hypochlorite before introduction into the root canal may increase its activity. Further studies show that when irrigation solution, preheated irrigation solution, touch the canal wall, its temperature will fall down rapidly and equals to body temperature. So instead of making preheating, we can use intracanal heating by using activation methods such as sonic, ultrasonic activation, lasers, and so on. Now, the concentration of sodium hypochlorite. In the literature, we can see different irrigation solution of sodium hypochlorite, starting from 2.5, 3%, 5%, 7%, or any other dilutions. Let's compare high concentration versus low concentration. High concentration sodium hypochlorite preparation have more ability against Enterococcus faecalis and Candida albicans and other microorganisms present into the dentinal tubules. Besides that, higher concentration sodium hypochlorite possess better dissolving ability of the organic tissue. But we should keep in mind that increasing the concentration of sodium hypochlorite is more toxic than lower concentration. Now, let's illustrate the action of sodium hypochlorite and compare it to the properties of ideal irrigation solution. Regarding flushing debris, sodium hypochlorite is good in this job. Also, it possesses good lubricant action. Antimicrobial properties is super wonderful. The low toxicity level requirement of ideal irrigation solution, as we said before, sodium hypochlorite doesn't fulfill this requirement. It shows good tissue dissolving ability, and at last, the sodium hypochlorite, as we said, can eliminate smear layer. Another important irrigation solution is chlorexidine. This type of irrigation agent is used in wide range of concentration that lies between 0.2 up to 2%. So we may see different dilution. Mostly, we recommend to use 2% chlorexidine. This agent has been known mostly as a very good antibacterial effect. Besides that good antibacterial effect, it shows good substantivity or long-term effect, as it can be very effective for a long period after its application. Also, chlorexidine showed low toxicity level to the periradicular cells when compared to sodium hypochlorite. But the major drawback of this agent is discoloration. Besides that, chlorexidine is unable to remove smear layer just like sodium hypochlorite. The extrusion of chlorexidine into soft tissue should also be avoided, as this material is irritant to the periradicular tissue, and some studies show that extrusion of this material will postpone healing of periradicular inflammation. An important thing I want to emphasize: sometimes we face cases of retreatment, failed or previous poor root canal therapy. In these instances, we have a high rate of gram-positive bacteria. These are very resistant bacteria and need a super powerful irrigation solution to be killed. So, in order to deal with this type of bacteria, I recommend to use fluorexidine in the irrigation protocols and retreatment cases. Now, also, let's compare the chlorexidine properties with the ideal requirements of irrigation solution. Flushing debris is good. Lubrication is good. The antimicrobial properties of chlorexidine is accepted and high. Low toxicity level is less than sodium hypochlorite. It can do tissue solving action, neither remove the smear layer. Another major irrigation solution we should discuss is EDTA. EDTA is the commonest chelator used in endodontic therapy. It has the ability to sequester di- and tricationic metal ions such as calcium and ferrous ion. It functions by forming calcium chelate solution with calcium ions of dentine, which make it more friable, and this way the dentine will be softer and the ability of removal of smear layer is promoted. The antimicrobial action of EDTA is sometimes accepted and can be illustrated by EDTA combines with metal ions from cell wall envelope, and with extended exposure of time, the surface proteins of bacteria is expected, and this will ultimately cause bacterial cell death. Now, let's talk about some properties of EDTA. The optimum concentration to be used is 17%. In the literature, we will see various concentration of EDTA, 5%, 7, 13, 15, 17, 18, 20, but in most literature, 17% is highly recommended and widely investigated. The efficacy of EDTA to remove a smear layer starts after 1 minute, and the recommended time of using EDTA is 2 to 3 minutes, as this time has shown to be very effective in removing smear layer and opening the dental tubule and peritubular dentine. Extended use of EDTA for prolonged period will have some damaging effect to the dentine, such as erosion and increasing dentine softening action, and this drawbacks should be avoided in our practice. So, as we said before, use EDTA for no more than 2 to 3 minutes and avoid prolonged uses. The recommended volume for each canal is 3 to 5 milliliters. The action of EDTA when compared to the ideal irrigation solution: flushing debris is good. Also, it is a good lubricant agent. It possesses some antimicrobial properties. The toxicity level is sometimes high, and tissue solving ability is low, but the major action of EDTA is the elimination of a smear layer. Those were the major irrigation solutions. We may see in the markets different brands of irrigation solutions. All of these solutions are aimed to fulfill the ideal requirement of irrigation agent, but unfortunately, none of them was capable of doing so. One of the irrigation solutions you might experience is BioPure MTAD. This irrigation agent is composed of doxycycline, citric acid, and surfactant. This agent found to be efficient in removing smear layer. It has a conductory antimicrobial efficacy and causes less dentine erosion when compared with EDTA. Another irrigation solution is a Q-mix. Q-mix is a fluorexidine mixture in which EDTA and surfactant is added. This irrigation agent has shown higher efficacy than sodium hypochlorite and chlorexidine alone against Enterococcus faecalis and Candida albicans. Also, the ability to remove a smear layer of Q-mix was investigated in comparison with EDTA, and smear layer removal ability of Q-mix was shown to be better. Nanoparticles-based disinfection. Nanoparticles is the new trend in dentistry and in all life fields. In dentistry, the recent advancement of nanoparticle technology has led to increased interest and introduction of nano-based particles, which could be used in endodontic irrigation. These particles have a nano diameter ranging between 1 to 100 nanometer. They possess a unique feature such as increased chemical reactivity, and also they provide a large surface area and a broad spectrum of antibacterial activity. For example, regarding nanoparticles-based disinfection, we have the chitosan, the zinc oxide, and the silver nanoparticle. Now, an important subject we should mention here is the interaction between irrigation solution. As we know, none of the irrigation solution available nowadays is able to fulfill the ideal requirements of root canal irrigation. So, combination of two or more of these irrigation solution is a must. But unfortunately, some interaction between these irrigation solutions or agent can occur. For instance, when sodium hypochlorite interacts with EDTA, this will cause the loss of sodium hypochlorite activity as EDTA decreases the hypochlorite ions available to interact. Another very important interaction happens between sodium hypochlorite and chlorexidine. This interaction will lead to formation of an immediate form of an orange-brown precipitate known as a parachloroalanine. This precipitate have very determinational effects such as erosion of the internal tubules, occlusion of these tubules, and also it is highly carcinogenic. And for sure, we don't want to introduce such a material inside the root canal of our patients. In order to avoid and overcome this interaction, we should thoroughly and perfectly remove sodium hypochlorite particles by using distilled water, normal saline, or even ethyl alcohol 96%, which showed good efficiency in removing sodium hypochlorite particles and less rate of formation of such a precipitate. Another interaction happens between EDTA and chlorexidine. This interaction will form a white precipitate that reduces the ability of EDTA to remove the smear layer. Now, the irrigation protocols. It's a very important subject we should discuss. There are very different irrigation procedures or protocols illustrated in the literature. Instead of telling which one is the better, we may understand what do we need from our protocols, what goals to achieve, and what things to avoid. We said earlier that each solution has certain advantages and drawbacks. These features must be kept in mind and well studied in order that we could obtain the maximum effect and reduce the side effects and the harmful interaction between the irrigation solution. The irrigation protocol I follow in most of cases is I use 5.25% sodium hypochlorite for 30 to 40 minutes starting from the beginning of root canal therapy. At this stage, what objective we did? At this stage, we obtained high antibacterial ability of sodium hypochlorite and removal of organic materials. After that, the sodium hypochlorite is rinsed with 5 cc distilled water to prepare the canal to receive the next irrigation solution, which is EDTA. By using 17% EDTA for 1 to 3 minutes, we will obtain the ability to remove smear layer. During this time, we may activate the EDTA for 30 to 60 seconds to promote its action. The next step, after flushing of EDTA, we can return back to sodium hypochlorite for 2 or 3 minutes in order to increase the ability of the sodium hypochlorite to kill the bacteria lodged deep within the dentinal tubule. But some literature stated that this step might increase the harmful effect or the erosive effect of sodium hypochlorite on the root canal walls. Also, they might affect the physical properties of the dentine. So we may escape this step or do it. The final step is using fluorexidine 2% for 1 to 2.5 minutes to get good and substantive antibacterial effect. Following that, we may or may not remove the excess of chlorexidine depending on some articles. The articles are in controversy regarding removal of chlorexidine after its application. Some authors recommend chlorexidine flushing in order to reduce the risk of discoloration, while others say no, in order to get the maximum antibacterial effect of chlorexidine. And also, as we know, chlorexidine promotes the bonding to resin-based sealer and cement. So in the literature, there is controversy between removing the excess of fluorexidine after its application or not. After that, the canal should be dried, and now it's ready for the obturation. Irrigation activation mechanism. It's an important subject. Its importance lies that activation promotes irrigation penetration within the dentinal tubule. Besides that, it has the ability to boost the tissue dissolving ability and antibacterial activity of the irrigation solution. Also, activation or agitation of the fluid will decrease the time needed by the irrigation agent to reach their maximum effect. Some terms associated with irrigation activation. Cavitation, which is formation of bubbles in a liquid, typically by moving of a propeller through it, while acoustic streaming is a steady flow in a fluid driven by the absorption of high-amplitude acoustic oscillation. Apical vapor lock. What do we mean by that? It's the formation of air bubbles in the apical area that limits fluid exchange and produce what is called the dead zone. These air bubble formation in the apical 2 to 3 millimeters will reduce the efficacy of irrigation agent to penetrate and well address this important area. So apical vapor lock should be kept in mind and dealt with properly during irrigation procedure. Now, what are the categories of agitation or activation technique? We have two categories, which is the manual agitation technique and machine-assisted agitation technique. For the manual agitation technique, we simply can use the endodontic fires or gutta percha by simple up and down movement after we soak the canal with the irrigation agent, so that we are increasing the activity of the irrigation solution. This method showed a low effect and may cause hydrogenic errors, especially if we use the endodontic fires, who may end up with ledge formation, perforation, strip perforation, so we should avoid using this method. Some types of irrigation needles, such as Navitip FX, comes with a preloaded brush that may benefit in canal wall scrubbing and irrigation solution activation. But its efficacy is lower also when compared to the more recent activation mechanism. Now, let's move on to the second category, which is machine-assisted activation. There are various activation methods that lies within this category. The earlier form of activation in this type was the rotary brush, which brushes are mounted on handpiece to facilitate debris and smear layer removal. This microbrush operates at a speed of 300 revolutions per minute, and they're not directly used or intended to deliver irrigation solution into the canal space. Their efficacy seems to be less when compared to recently advanced irrigation mechanisms. The second technique is sonic activation or agitation. Many devices were introduced in the market which utilize sonic vibration to agitate or activate the irrigation agent. One of them, and most commonly known, is the endoactivator. This device utilizes safe and non-cutting polymer tips. It has good safety and benefit. It doesn't cut dentin, it just agitate and irrigate the the irrigation solution. It does so by production of acoustic streaming and cavitation phenomena, which increase the activity of the solution agent, and this will lead to better activation and penetration of the solution. This device has a 3-speed options, which is 10,000, the default one, 6,000, and 2,000 cycles per minute. Also, it comes with various tip size, which are color coded. The yellow, red, and the blue one. We should use the tip that fit loosely within 2 to 3 millimeters of the working length and ensure that it will work freely and without any engagement to ensure maximum activation. We can see in this video
the endoactivator system uses strong and highly flexible polymer tips to safely activate various intracanal reagents and vigorously produce the hydrodynamic phenomenon. This new technology provides an advantage over traditional methods and offers a safer, better, and faster way to achieve success in the following clinical applications: three-dimensional debridement and disruption of the smear layer and biofilm, placement of calcium hydroxide and MTA around root curvatures, removal of residual obturation materials during retreatment procedures. Let's take a closer look at this new, innovative, and easy-to-use technology. The endoactivator system is comprised of a cordless, contra-angled, and ergonomic handpiece that drives the endoactivator tips. This handpiece is operated by pressing the light touch on-off switch, which activates the strong and flexible polymer tips. The 3-speed sonic motor switch provides options of 10,000, 6,000, and 2,000 cycles per minute. When the driver is activated, the power defaults to 10,000 cycles per minute, which is the recommended speed to maximize debridement and disruption of the smear layer and biofilm. Ultimately, the other speeds are selected based on different applications and the power needed to effectively accomplish the clinical task.
Now, let's talk about ultrasonic activation. The difference between sonic and ultrasonic activation is the power range. The sonic activation devices operates at 20,000 or below kilohertz, while the ultrasonic agents or devices use a higher range of power to operate. There are 2 types of ultrasonic irrigation found in the literature. The earlier form included simultaneous mix of ultrasound irrigation and instrumentation procedure. This type showed a lot of procedural errors, such as ledging, zipping, and perforation, because the dentine cutting procedure during instrumentation was uncontrolled. So it ended with some iatrogenic mistake. Later on, this type of instrumentation and activation, as you can see, is diminished. The other type, which is called passive, as it didn't contain instrumentation, also just contained the activation of irrigation solution, known as passive ultrasonic irrigation. Ultrasonic activation device, as we said, they operate at high energy level, 20,000 hertz or more. The Ultra-X ultrasonic device. This device operates at ultrasonic frequency of 45 kilohertz. It depends on cavitation and acoustic streaming to activate the irrigation solution. The generated frequency inside the root canal is automatically adjusted by this device to ensure maximum safety and function. Also, it is available in various tips that can make different clinical applications. Another feature of activation is negative apical pressure or endovac. This type of activation was addressed to deal with the apical vapor lock we talked about before. The flow of irrigation solution in the apical third, as we said, is very challenging. The first step in this method is introduction of irrigation solution into the bulb chamber. After that, we insert a very fine needle into the root canal and to which the suction device is inserted to remove the coronal debris. Subsequently, a microcannula equivalent to 32.02 taper remove the particles lodged close to the working length. The excess irrigant is then transported apically and ultimately by suction. Here we can see this technique of irrigation. Doesn't work. Okay. Laser activated irrigation. It's another category of the activation of irrigation solution. Laser activation could be at various ways, such as molecular level, such as in photoactivated disinfection, or at bulk flow level, as in laser activated aggregation. The mechanism of action depends on the generation of a secondary cavitation effect with expansion and successive impulsion of a fluid. There are various types of laser, various types that can be used in activation, and all of them showed a promising and good result in solutions activation. Now, let's talk about the gentle wave system. This type of activation is called the multisonic activation. This novel approach benefits from multisonic cleaning technology, and it only needs pulp chamber access. This type of device was aimed to fulfill the requirements of minimally invasive endodontics. And the first studies investigated the system showed a high potential of debridement when compared to ultrasonic activated irrigation. In this video, we will see the gentle wave procedure.
Patients want to save their teeth, but they don't want a standard root canal treatment. It's with that in mind we developed the gentle wave procedure, helping you ensure patients a higher standard of clean. Unlike standard root canal treatment, which relies on both biomechanical and chemomechanical means to remove infected tissue, the gentle wave procedure effectively cleans and disinfects while conserving precious tooth structure. Simultaneous cleaning of all canals, deep into dental tubules, isthmi, lateral canals, and other complex anatomy is accomplished through a proprietary technology that leverages multisonic ultracleaning, advanced fluid dynamics, and accelerated chemistry for improved patient outcomes. A few key features that set the gentle wave procedure apart. It all starts in the gentle wave console, where the procedure fluids are optimized through a process known as degassing. This reduces the possibility of apical vapor lock and maximizes tissue dissolution, debridement, and disinfection. Fewer files are used. With the gentle wave procedure, the job of the file is simply to provide an uninterrupted path for a three-dimensional fill. A sealed environment is generated between the tooth and the gentle wave procedure instrument to allow for constant refreshing of degassed procedure fluids and simultaneous evacuation of debris. It's in the procedure instrument that patented multisonic ultra cleaning technology enters the equation. The stream of optimized fluid entering the tooth creates a powerful shear force, which causes hydrodynamic cavitation in the form of a useful cavitation cloud. The implosion of thousands of microbubbles creates an acoustic field of broadband frequencies, which travels through the fluid into the entire root canal system. Gentle vortical flow is induced within the root canal system with a slight negative pressure at the apex. The result, unique to the gentle wave procedure, is unmatched cleaning and disinfection from the crown to the apex.
Well, thanks again for providing this special chance to share knowledge, and hopefully everyone will stay safe during this COVID-19 crisis. I'm very happy to receive any questions. Thanks again.
Thank you so much, sir, for an enlightening lecture for all of us and giving us information about the newer technologies which can be applied into the treatment of the patients, actually. So it was a beautiful and informative lecture, sir. Thank you, sir. So shall we move on to the questionnaire?
Yes, please.
So the first question is from Dr. Myra. What is substantivity?
Substantivity means long-term effect of the antimicrobial agent. This feature is highly effective in fluorexidine. Fluorexidine possesses a high substantive effect after its application. It can be active for even 40 up to 1 month after its application.
Okay. So the next question is from Dr. Jasmine. How to prevent sodium hypochlorite before using it for disinfection?
How to what? Sorry?
So how to preheat sodium hypochlorite?
preheating of sodium hypochlorite, we can use the syringe in a warm bath, and this will increase the temperature. But this type of method is low. As I said before, when we introduce the preheated sodium hypochlorite inside the root canal, it will equal the body temperature rapidly, and we will lose the preheating benefit. So I prefer to heat the sodium hypochlorite inside the canal by simply activating it.
Okay, sir. So next question is from Dr. Neil. How to prevent apical vapor lock? And one more question is, I would like to ask, what exactly forms apical vapor locks and how to prevent them?
Vapor lock, as we said, due to the movement of irrigation solution in the apical two-thirds, this, as you know, this area is very constricted and have very deltas and anatomical anastomosis. Air bubbles might form during irrigation procedure, which may impede the ability of the penetration of the sodium hypochlorite or any other irrigation solution. How to prevent them is by using slowly injection and keeping the irrigation needle away from the apex 2 to 3 millimeters. Also, this will reduce somehow the vapor lock, but it will not totally eliminate it. The more recent activation mechanism, such as multisonic, as gentle wave, and the endovac showed higher possibility of elimination of this effect.
Okay, sir. So the next question is from Dr. Neil again. As we say that higher the concentration of hypochlorite, it is good to provide high microbial activity. So why don't we use 10% of hypochlorite for root canal disinfection?
Okay. There's a controversy regarding the ideal irrigation solution of sodium hypochlorite concentration. Some studies reported that we can use 2.5, 3%, 5, 7, or up to 11, not just 10. But while we're increasing the concentration of sodium hypochlorite, we will have some determinational effect, such as the toxic ability to the periradicular tissue in cases of extrusion. So most literature recommend using 5.25% of sodium hypochlorite.
Okay, sir. Next question is from Dr. Ahmed. When you do activation, before instrumentation or after?
I actually do activation during instrumentation. After I remove the file, after the stroke, I do irrigation, activation, and refreshing of the sodium hypochlorite.
So next question is from Dr. Priya. Ultrasonics causes vibrations, and these vibrations will cause vapors. So isn't ultrasonic irrigation will create more vapor locks?
What? Sorry, I didn't hear.
So basically ultrasonics causes vibrations, and these vibrations will cause vapor locks. So is it true that ultrasonic irrigations will cause more formation of vapor locks?
Somehow it does so. Any irrigation activation technique, or even the passive irrigation without any activation, will create such an phenomena, as we can say. Sometimes, but the studies didn't reach an ultimate point. Which method can prevent this formation? It's not evenly possible to know. The testing methods, the difference between laboratory and clinical circumstances. But I told you ultrasonic is better than sonic or passive in activity. And regarding the formation of apical vapor lock, I recommend using the endovac or the gentle wave procedure.
Okay, sir. Absolutely. Next question is from Dr. Ahmed. Is sodium contraindicated in open apexes?
Sodium hypochlorite in open apexes, how to deal with it? The concentration, the point here, we should ensure safety with such instances. We can reduce the concentration of sodium hypochlorite to 2.5 or 3%, But the most important thing, even if we use higher concentration, we should utilize safety irrigation procedure by using side-vented needle, preventing the locking of the irrigation needle inside the root canal, and slowly advancing of the irrigation solution.
So I hope it is not contraindicated in those cases.
Did you please?
Like sodium hypochlorite is not contraindicated for open apexes, right?
No, it's not contraindicated at all. We should proceed with sodium hypochlorite, but we must guarantee safety.
Okay. So next question is from Dr. Priya. How to preheat sodium hypochlorite outside the canal, as we don't have equipments to heat it inside the canal?
I told you before, preheating is I can say it's useless. Preheating is useless. Simply, as the preheated sodium hypochlorite enters the canal, it will be equal to body temperature. But if you want to do so, you can put your irrigation needle inside a hot bath. Simply bring a rubber barrel with hot water and bring the
water bath
needle inside it.
Okay. And we are heating it inside the canal using
any method of activation, such as sonic, ultrasonic activation. As you know, activation increases the movement ability of the particles, and this will increase the temperature of sodium hypochlorite. The most effective method of heating is laser, as I remember.
Okay. So next question is, what are your views about using hydrogen peroxide as root canal irrigant?
Hydrogen peroxide was used previously, but it has so many damaging effects. So nowadays it's limited. It's start to be limited in actually in clinical application. We have more developed, more widely used agents, sodium hypochlorite, EDTA, fluorexidine. We can depend mostly on them. I don't use it in my application.
Definitely, sir. Next question is from Dr. Lakshman. What can be the treatment of rubber dam allergy?
Rubber dam allergy. It's a bizarre question and very difficult to answer. Normally, the percentage of people having rubber dam allergy is low. We can use rubber dam products that don't contain latex. I guess there's some type of this are available.
Okay. Next question is from Dr. Ahmed. Do you use irrigating protocol? Okay, we'll move on to the next one. Which temperature should be kept for sodium hypochlorite?
The ideal and most effective temperature is reported to be 60 degrees. But we can elevate this temperature. For instance, I told you before, the body will start to equal the temperature of sodium hypochlorite. We can't keep looking for the ideal temperature. Instead, we ensure better time, good concentration, and activation of sodium hypochlorite instead. We can depend on that.
Okay, sir. Next question is, so how can we prevent apical locks manually if we don't have the technologies, as you have shown in your videos and these slides? So can we have some method which can be used manually to prevent apical locks?
Any irrigation procedure will produce vapor locks. I told you before, slowly advancement of the irrigation needle and slowly advancement of the irrigation solution will reduce this determinational effect, but anyhow, it will never prevent this to happen.
So next question is from Dr. Priya. What if patient is having allergy from sodium hypochlorite? Which irrigant can replace it?
We can depend on fluorexidine and EDTA only. If the patient have allergy to sodium hypochlorite, we'll switch to other agents such as the EDTA and fluorexidine, but unfortunately we will lose the ability of sodium hypochlorite to dissolve the organic tissue.
Okay, sir, definitely. Next question is from Dr. Ahmed. Do you do irrigation protocol with instrumentation or separately?
I started my irrigation protocol at the time of canal negotiation. Once I do access opening, I flood the chamber with sodium hypochlorite. And as I said, we need between 30 to 40 minutes. I read an article who say so, in order to have maximum effect of sodium hypochlorite. After completing instrumentation, I do final flushing and activation of sodium hypochlorite, and then move to the next irrigation agents such as EDTA or fluorexidine.
Yes, sir, absolutely. Yes, sir. Next question is from Dr. Priya. How do you dry canals after irrigation?
Dryness of canals, I use in my clinical protocols paper points. Also, sometimes I use ethyl alcohol. It's very effective in drying the canal, starting from 70 up to 7%. They are very effective in removing the moisture within the canal.
Yes, sir. So with this, we are end up with the questionnaire. And it has been quite an extensively amazing lecture, sir.
Thank you so much. It's my pleasure to be here with you.
Sir, actually, the question which I just asked, last one, there's an explanation, actually a doubt basically. Since paper point causes bleeding due to its tip, so how can we dry the canal with the chemical?
Paper point cause bleeding?
Yeah, from the tip actually. It has a sharp tip at the end.
I will answer it. Paper point, if they got bleeding in this tip, it has many possibilities. Like we didn't actually get a good irrigation procedure for the apical 1/3. Still, there is some vital pulp tissue that intends the bleeding. The other things, controlling working length. If we don't control our working length, we are simply over instrumentation, then we insert an overextended paper point. Besides that, oozing from periradicular tissue in cases of like open apexes or large periapical foramina might sometimes do so. So my advice here, to ensure a very dry paper point, we should control working length, we should provide sufficient time and activation method of our irrigation solution, and also we can, another possibility, before I forget, maybe we will have lateral canals that cause this oozing.
Okay. So one more question is from Dr. Khalid. Do you wait for 30 minutes after irrigation with sodium hypochlorite?
If I start using sodium hypochlorite from the beginning of treatment, I insist on doing so. I should at least do it for 30 minutes.
Okay. So one question is from Dr. Priya. How do you disinfect canals after placing calcium hydroxide?
Disinfection of canals after placing calcium hydroxide. Does he mean removing of calcium hydroxide?
Might be.
The removal of hydroxide is a controversy. I read a lot of articles regarding this subject, and none of them was able to remove calcium hydroxide between appointments. Neither instrumentation with larger files, various activation methods, all of them. The best one, I guess, was ultrasonic. I heard 97 or 96%. Still, there are some remnants of calcium hydroxide. And this will lead us to shift to single visit endodontics wherever possible.
Absolutely. Okay, we might take the last question. How to disinfect canals in cases where we need to do regenerative endodontics?
This is a total different object. We might reduce the concentration of sodium hypochlorite as it is detrimental to the periradicular tissue. Also, we will, regarding the antibacterial activity, we will count on the bioactive materials such as MTA, biodentine. They possess a very well antibacterial effect.
Okay. So next question is from Dr. Ahmed. If you have open apex and you cannot dry the canal, what can we do?
If the canal is not dry, I prefer to put intracanal medication, such as calcium hydroxide, and leave it for at least 2 weeks, 10 days to 2 weeks, and then I will return to do my endodontic therapy. A general rule, you should always follow: if the canal is not dry, you can't obturate.
Okay, sir. So with this, we'll move on to the end of the session. And thank you so much, sir, for the beautifully explained lecture. It was very well charted, actually. And yes, sir, it was. Yes, sir. So it was actually an informative lecture for everyone, and a lot of regards are being given to you.
Thank you so much. Thank you. Regards to you all and your team. Thank you so much.
Thank you so much, sir. With this, we'll move on to the commencement of the session. And I would like to inform all the participants and all the viewers to kindly visit the description box for the speaker schedule for the participation of certificates, etc. So with this, we'll move on to the end. Thank you so much, sir.